Dr. Ryan Cole, thank you so much for joining us. Really excited to have this conversation. I haven't been able to have this with you as much as I've wanted to because until the beginning of this year, I was primarily on YouTube and they constantly censored everything. But now that I'm a Rumble exclusive show, I'm finally able to dive into all of the things I've been wanting to, all the questions that I have, the information that you have to share with people. So thank you so much for being here.
Kim, it's an honor to be here with you today, and I look forward to the conversation. Just like you, there's so many things I've tried to discuss, and as you mentioned, the censorship, the inability to share just basic science has been really mind-boggling.
So one of the first things that really brought you to the forefront and in the spotlight, I would say, is you really started to examine the blood, how blood was affected by the vaccines, by the virus. Tell us about the blood clotting. What does the virus, what does the vaccine do to our blood?
That's a great question. And in retrospect, as we've looked at the science over the last 3 years, early on, as the virus itself was spreading, I sit here at this microscope all day long and look at pieces of people, and in the biopsies that I see, I saw a lot of micro blood clotting, and I thought that was kind of unusual. And I ran a full service medical laboratory, not just biopsies, but blood work. And I noticed interesting patterns in the red blood cell counts, the white blood cell counts, the platelet counts. So during COVID, the wave before the shots rolled out, I noticed there was strange changes in blood parameters. And then it was confirmed under the microscope as well. But fascinatingly, when the shots rolled out, I saw an increase of clotting under the microscope, as did many of my pathology colleagues who didn't speak out, but would speak in private circles. And we would communicate and they would say, hey, it's interesting. I'm seeing all these micro clots in this organ or that organ. So early on, we knew that COVID was a clotting disease. And more than anything, everybody would hear about the ground glass in the lungs and the odd radiology appearance. But really, that spike protein from the virus, as well as the spike protein that the body produces after these gene-based injections, or even from the protein-based Novavax, that spike protein is a clotting agent. So our agencies that chose to push forward with a quote vaccine program chose the wrong protein. This protein causes platelets to clump. And those are the little tiny microscopic Band-Aids in your blood that when you scrape your knee, they form that nice little patch so the bleeding stops. So that spike protein causes platelets to clump. It causes red blood cells to clump. But even in the absence, so you can take all those platelets away. There's a wonderful colleague in South Africa, Dr. Reza Pretorius, and she and Dr. Kell out of the UK and Dr. Jordan Vaughn out of Alabama, they did a bunch of studies showing that if you take even platelet poor plasma and put the spike protein in, it will cause proteins to clump as well. So it's not just the platelets clumping, it's proteins clumping, and it's unusual amounts of protein clumping. And thankfully, was this happening in everybody? No, there were a lot of predisposing conditions, as everybody's heard about. But that's what was highly concerning, as we had a very what we call thrombogenic or clot causing protein. And so, I got smeared and demeaned for using the word clot shot early on, but we knew even the FDA withdrew J&J because they were having clotting problems. And if we look in the adverse event reporting systems around the world, Moderna and Pfizer have more clots than J&J or even the AstraZeneca shot did. So the primary process of COVID, of this S protein from SARS-CoV-2, is inflammation of the blood vessels, which would lead to secondary clotting. It's really, really a concerning new pattern as far as certain viruses go.
Why do you think the AstraZeneca and J&J vaccines didn't cause the same level of clotting as the mRNAs? Because from my understanding, those two vaccines, J&J, AstraZeneca, those are the adenovector vaccines, right? So it's similar that it's injecting the message of spike protein to make spike proteins in your system, right? But it's just done through a different methodology. mRNA does it one way, and these other vaccines do it another, but they're still telling your body to make spike proteins, unlike other types of vaccines, more traditional vaccines that don't tell your body to actually make the spike protein. So if they're both saying do this, why do you think the mRNAs were more powerful?
You're correct. So they are slightly different methodologies. So those adenovirus vector injections, they would use what we call complementary DNA. The advantage of that is it doesn't persist in the body like the mRNA does. So the synthetic mRNA in the Pfizer and Moderna, we know from studies by Dr. Roltgen out of Stanford, would persist in the body for at least 2 months, the mRNA itself in many patients, and would continue to make spike protein. Whereas the adenovirus vector shots would make a big burst of spike protein for a window of time, and then it would taper off. And in those two, with those adenovirus vector shots, what we tended to see was the body would form an autoimmune antibody against your own platelets, called platelet factor number 4. And when that would happen, you'd have an autoimmune attack, then your platelets would clump and you would form big clots. So we heard about these cavernous venous thromboses. That's this area where blood will pool on the top of the brain and the top of the skull. And so you'd form a big clot and then blood would hemorrhage around that. So that's why J&J was pulled early when we saw many women pass away from this process. So the amount of spike protein by those adenovirus shots was a lot up front, but then would taper. Whereas Pfizer and Moderna are this persistent low grade, just spitting basically of spike protein over time because the body doesn't break down this synthetic mRNA. And so this criticism, oh gosh, mRNA, it's safe, it gets broken down in a few minutes to a few hours in the body. Yeah, sure, real mRNA does. You and I are making it right now to make muscle and bone and healthy skin cells. We're sending messages from cells in our body all day long to make proteins. Naturally, we need a certain amount of protein, then the body turns the signal off. Well, these synthetic mRNAs that were formulated to evade the immune system, those persist. And there's not one good study yet, mammalian or human, showing when the body stops altogether making spike protein or when these this synthetic mRNA shots, Pfizer and Moderna, are actually degraded. That's the big concern.
Do you think it's because with the adenovirus vector vaccine, those are, from my understanding, they're using a virus that exists that's harmless to humans, and then they're putting the message inside of it, the spike to make spike proteins, and then they're injecting that into us. Is the process that's happening that's different? Is our body then fighting that new virus? It's detecting this new virus, it's fighting it off, and then it kills it off, going through that natural process. Versus mRNAs, what is your body? How does your body get rid of that? I mean, it wouldn't fight it the same way it would this virus, this like monkey virus. What some of the viruses that they use? I think it was like I
Yeah,
don't know if it
you're
was a
right. Yeah,
monkey virus, but a
it
gorilla or
was.
something. Right? They were
Yeah.
using that, and they were taking this virus from a different animal that has apparently no impact on humans. And then do you think it's because the system recognized that virus and said, oh, this is something that shouldn't be here, we got to fight it, unlike mRNAs that didn't really know what to do with it? I mean, is there a theory as to why? That's just what I'm thinking in my mind, but I'm not a doctor
Yeah.
or a scientist.
No. That's a great question. And using another virus to be basically the shuttle for the sequence to make the spike protein was the concept behind those adenovirus vectors. And yes, they used other mammal adenoviruses. So, hopefully or supposedly they won't cause quite an infectious type process in humans. However, this technology isn't brand new with the adenovirus vectors. We tried this for gene therapy in inborn errors of metabolism going back in the late 1980s, early 90s. And even in those trials, in gene therapy trials, there were immense problems with clotting. So it's known that this shuttle mechanism of using an adenovirus, it wasn't without risk or harm in and of itself. Now, you are correct in the sense that the mRNAs from the Pfizer and Moderna, it is different. This is a sequence wrapped in a lipid nanoparticle and then wrapped in polyethylene glycol, which is also dangerous. We could get into that. And so it's not a virus, it's a little fat package with a sequence in it. And then that sequence hijacks your cells and makes your cells into a spike protein factory, which as many people may have heard me say in a hearing with Senator Johnson, human cells are meant to make human proteins, and human cells are not meant to make foreign proteins. So once your cells start to make a protein that's not native to human tissues, those become a target of your immune system. So the fact that we approach this, from two different novel routes, be it an adenovirus vector or be it lipid nanoparticles plus an mRNA sequence, this was all novel. And I'll go back to even before that. Coronaviruses have never been amenable to vaccination. And we've seen this as the pandemic's gone along. Here we are 3 years later. The shots that some people sadly are still mandating are expired because the variants of the virus, the Wuhan virus variant, went extinct over 2 years ago. The BA4, BA5 variants in the bivalents, those are essentially extinct as well. So we now have expired shots for extinct viruses. And if you look at the history of coronaviruses across mammalian species, there are 40 plus species or subspecies of coronaviruses in the coronavirus family that affect cows and pigs and dogs and cats and et cetera, et cetera. But we've never really had a successful coronavirus vaccine because this family mutates ahead of our efforts. And when that happens, there's a condition called antibody-dependent enhancement. So everybody talks about antibodies. Well, a good antibody is your friend. And so grandma had measles 85 years ago, and grandma's still immune to measles because there are portions of that virus that stay the same for eons. Other virus families mutate differently. So there's a reason that Anthony Fauci's holy grail of vaccines, an HIV vaccine, never occurred because it also has a spike protein of a different type. But 40 years later, there's still not an HIV vaccine because it mutates ahead of vaccinal efforts. Coronaviruses do the same thing. They're constantly mutating point by point by point, an addition, a deletion, an addition, deletion, which changes the shape of the protein, which changes the sugars that stick to it, which changes the ability of those antibodies to work in the way that they should. So if they bind to the virus and then, their little tail on the antibody, everybody knows the Y shape of an antibody now. So if that antibody binds and what we call neutralizes or sterilizes, then the body comes and gobbles up the virus it's bound to. Hooray, virus cleared. But if it binds to it and doesn't turn off, then your little garbage truck cells, your Pac-Man cells, they come in and then they engulf it and they don't neutralize it. Now the virus uses your own immune cells as a factory as well. And then you end up with even more cytokines and even more inflammation. So it Trojan horses itself into your immune system. That's a bad thing. This happened with the dengue fever vaccines in the Philippines back in 2017. And so one serotype of dengue fever, they vaccinated. And then the next season along comes dengue season. And the children that got vaccinated ended up with more hospitalization and more death the next season. So this is the same thing. Hotez, who's one of the godfathers of vaccinology, he testified in Congress back in March of 20 or April of 20, and saying, "Look, this is a gamble that we're trying here because it's known in coronavirus families that we can have these enhancement reactions. That's why we never had a SARS-CoV-1 vaccine. It never got out of mammal trials because of this risk and the amount of damage caused in mice and ferrets, et cetera. Same thing with MERS trials." And we knew going into this, approaching a coronavirus with a vaccine was a scientifically inept idea from day one.
Do you think that the vaccines then caused all of the mutations? That was one of the questions about why we had such rapid mutations. Suddenly, there was a long period of time when the virus seemed to stay in its original, maybe Wuhan form, maybe one right after that, one mutation after that. But then it didn't mutate for a while, but then suddenly it did start mutating very quickly. And there were scientists early on saying, if you vaccinate, you're going to end up creating more, the virus is going to mutate its way around this vaccine. Do you think that's why we have so many different variants now? Or is a coronavirus just mutating quickly because that's what coronaviruses do?
Yeah, and anytime anybody got infected, they had countless variants to start with. So the construct that a person's infected with just one variant You actually have a swarm of viruses. There may have been the preponderance of that swarm being, um, that one subvariant, but you're constantly seeing mutations as that virus turns over in the cells of your body. My colleague, Dr. Geert Vanden Bossche, out of Europe, brilliant scientist, vaccinologist, he warned of this early on. He was correct. There's another colleague that I follow that I really admire, biologist JJ Cooey, and JJ has talked about this swarm concept of the virus. But I think you're correct. I think the selection pressure, the evolutionary pressure, again, this goes to an antibody is either a friend or an enemy, and we're forming this very narrow band of antibodies and allowing the virus to do these football end runs around what our immune system is trying to do. And basically, we put blinders on the immune system by just focusing on these variants in these shots. And then the immune system is looking for that one spike protein, but to the detriment of not being able to see all those other variants forming. And that does put evolutionary selection pressure on that virus. And all of a sudden, like you said, we have all these variants. So again, in retrospect, I did PhD immunology work back in medical school, and just knowing these basic principles of immunology and virology, it was very perplexing to many of us in the field, looking at what the efforts and the goals and the stated plans and the rollouts of these shots. It was never a good idea from day one. And to think that whatever political medical bureaucrat at the top was saying, hey, let's do this, and we're trying to blow the whistle and say, we're crying foul, time out. No, let's look at this from an historical perspective, and let's look at this from a basic science perspective. I like to joke that obviously common sense is not so common, but now common science is no longer common.
Yeah. I mean, there's clearly a lot of motivations from different, politicians had a motivation to want to roll out and rush out the vaccine because they wanted to look like they were doing something. People were scared. And so they wanted to look like they were doing something that could potentially save you. That was their motivation for sure. And then, of course, the pharmaceutical companies had an obvious motivation, which is gobs and gobs and gobs of money, which they ended up making. So there was those motivations, and it didn't really matter if it worked or not. It seemed it was just the Band-Aid to get people to calm down, to get people to. But ultimately, it's led us down this other very dystopian path of mandates, and now the different side effects that people are experiencing from these vaccines. So that I want to go back to that because it sounds to me like you're saying there's two different things going on when it comes to the vaccine. There's the spike protein, which we're going to get. I would like to get into more of what the damage that's causing to people. Maybe that's linked to why there's you've mentioned a rise in cancer rates. We know that there's fertility issues, or seems to be a whole host of issues going on, heart problems. Maybe that's the spike protein, and I'll have you kind of dive into the how and the why. But it sounds to me like what you're saying is even before the mRNAs and these adenovirus or vector vaccine, I keep getting that word wrong. But
You're doing great. You're doing great, Kim.
it sounds to me like you're saying even before they programmed them to, or they put in the little code to tell us to make spike proteins, that technology causes blood clotting. So is it the spike is it what they used mRNAs and these adenovector vaccines? Is it what they use them for that causes blood clotting, or is it the mechanism itself, no matter what you sequence it with, that causes blood clotting?
Yes, that spike protein, it causes clotting.
So it's the spike protein.
Well,
So if they used
plus
mRNA for
the
something
adenovirus.
else.
Yeah, I mean, plus the adenovirus vector. I mean, again, historically, we know in gene-based therapy trials with adenovirus vectors, clotting was always a problem, and that's a slightly different pathway, but just picking the wrong protein. There's a little protein that wraps the RNA itself in the virus called the nucleocapsid. Had we chosen that protein instead of this spike protein, it doesn't cause these same clotting pathways. So the scientists that pushed forward this program chose the wrong protein. They chose
Okay,
the wrong
so
protein.
So they could have gone forward with like what the Cubans did, where they took a different part of with their vaccine. They didn't use the spike protein, they used a different part of the virus. I don't know what mechanism they used to deliver their vaccine. I don't think it was adenovector or mRNA. I think it was uh, subprotein. They did a sub unit
Yeah, protein
type,
subunits. Yeah, protein
right? That's what they
subunits.
used.
And
So
and go ahead.
so what? So you're if we chose a different part and used mRNA technology for with that other piece, you're saying that blood clotting may not have happened, and that we may
It
not
may
have
not.
all of these other side effects.
Correct. And that's a big concern is we chose the most clotting aspect of the virus. We chose the one where we knew if it mutated, it could cause an enhanced reaction. And but even so, using more of those conserved sequences, be it the membrane of the virus or the envelope of the virus or that nucleocapsid, those would have caused less clotting, and those regions don't mutate as much as the spike protein does. They're a little harder for the immune system to get into to neutralize the virus. But again, I'll just go back to the simple science that historically trying to vaccinate against the family of coronaviruses was
Right,
was a non-starter. It was a
right.
non-starter.
I guess what I'm just trying to figure out is the technology of mRNA and these adenovector vaccines, is the technology bad and we shouldn't ever use the technology, or is it just that the scientists that were working on this chose the wrong part of the virus?
So scientifically, I want to say never. But in terms of the targeted focus of this technology, does it have application for certain inborn errors of metabolism? Yes. Does it have potential for targeting certain cancers? Potentially. However, the technology, and this is kind of one of my big platforms at this point in terms of message, a lipid nanoparticle plus an mRNA platform, be it for influenza or RSV or tuberculosis or HIV or any other pathogen. The problem is human cells are meant to make human proteins. Anytime a human cell is making a foreign protein, it's now a target of your immune system. Dr. Hagemann out of Germany in the European Journal of Immunology proved this, that our immune system was committing what we call ADCC, antibody-dependent cellular cytotoxicity. So he proved our cells were being blown up by our immune system, any cells that were making the spike protein. Sadly, there was an autopsy case of a 14-year-old girl who had just gotten her third shot out of Japan, and the pathology images in that paper that just came out a day or two ago show the vast amount of organ damage in every organ in the body. And this is the other message, is the lipid nanoparticle was designed to go everywhere. It was designed to carry chemotherapeutic agents to the brain. It crosses the blood-brain barrier. You don't want a foreign gene and a foreign protein in your brain cells. And it goes to the liver, and it goes to the spleen, and it goes to the bone marrow, and it goes to the reproductive organs. So to use a lipid nanoparticle, and again, we were not told the truth by our governmental agencies. They said, oh gosh, it just stays in your deltoid muscle in your arm and you're fine. And then subtly, they took that messaging off of their website several months ago when they realized, oh, these scientists who actually know their stuff are exposing what we're seeing. So a lipid nanoparticle plus a pathogen gene is a horrible idea. It's a horrible idea. It is not how we vaccinate, because human cells aren't meant to be expressing these foreign proteins, and our immune system does extreme damage to our own body and our own organs.
So let's talk about why we're seeing an increase in cancers, in heart issues. Seems like, but the heart issues, I think we all have an understanding that the vaccines are causing heart problems. Maybe we know that happens. They're now admitting that. You probably know the why. They just tell us this, and we say, okay, this is happening. But there now seems to be also other issues with maybe fertility problems, cancers for sure. Can you walk us through the how and the why this is happening?
Certainly. So the virus as a whole is big enough that it really can't get through tight junctions in the body, but the spike protein is tiny and it can. And there were early studies showing that the spike has two subunits, an S1 and an S2. And studies early on in mice models showed that S1 crosses that blood-brain barrier, as does that lipid nanoparticle. So my friend Dr. Urso says, look, in order for the virus to get through, you have to open the whole door. But that lipid nanoparticle and that spike protein can slip under the crack of the door. So these small, tiny particles can get into the heart. And everybody, as you mentioned, knows about, the heart inflammation. And I have sadly, plenty of autopsies that have come from around the country and the world. And we can stain with special stains in a laboratory and show the presence of the spike protein in not only the heart, but more concerning, there's a lot of neurologic damage because that little protein can get into neural tissues, into the brain, into the peripheral nerves. You hear of a lot of vaccine injured with peripheral neuropathies. And so it's not just the immune system attacking the cells, but it's the spike protein getting into the organs and then saying, here, now I'm a target. So reproductive organs, you brought that up. We have tissue samples. My colleague, Dr. Arne Burkhardt in Germany, I was at a conference in Stockholm, Sweden a couple months ago, and he presented testicular samples of autopsy patients, a young man and an elderly gentleman. But the testes were full of spike protein. In another conference I was online with him a couple of weeks ago, he shows tons of spike protein in the ovaries. And we know from the biodistribution studies, not only the early ones that came out of Japan that Dr. Byron Bridle got the information for out of Japan. He's in Canada. I met with him last week. But also the TGA in Australia, they had the records showing how this injection biodistributed. So they knew as well it was concentrating in the ovaries. And so each time one gets a dose, one is getting more and more and more spike in these individual organs. It's not as though, we got one and it's just tapering off. We keep stacking these booster after booster into people. And we've seen birth rates in multiple European nations drop precipitously, 10, 20% in certain nations. There's certain nations that haven't reported their birth rates, like Australia, for months and months and months on end, when these used to be normal processes. All of a sudden, agencies aren't reporting what they're tasked to do. And then one organ, and this is, you hear a lot of POTS syndrome. I don't know if you've heard that term, postural orthostatic tachycardia syndrome. So high heart rate, low blood pressure, high heart rate. And so people have trouble regulating heart rate and blood pressure. And this is one of the major complaints in vaccine injured. And the reason for that is the lipid nanoparticle goes to the adrenal glands as well. And your adrenals control, obviously, your adrenaline, your cortisol, but also your blood sugar, your potassium balance, et cetera. And I have a couple of sad cases where the adrenal glands are full of spike protein. So under the microscope, we as pathologists can identify where this protein is being produced and which organs it's landing and which ones are being destroyed by the immune attack from that. So there's so many broad areas of the body. And again, this is why this is a bad technology. If it were, even if it were a traditional protein, it still would have outmutated our efforts. Like the Novavax is still just the Wuhan spike. And we know the Novavax had an elevated risk of heart inflammation and heart damage as well. And so even using a traditional protein vaccine against coronavirus has never been successful for basic science reasons. But using this technology has led to, sadly, the highest rates of vaccine injury that we've seen from compared to all vaccines combined. So that's the massive concern. And I think have you had Ed Dowd on your program?
Yes.
Yeah, Ed's wonderful. I had lunch with him in Maui a couple of weeks ago, and
Lucky.
yeah, what a wonderful human being. He's such a great guy, but he is so spot on statistically. So obviously I'm doing the science and the tissue assessment, and then he's showing it at the macro population level. And we had a great conversation. We have a small project we're going to work on together, diving into going onto the cancer mode. We have a way we're going to be able to look at the population statistics on cancer as well.
I have so many questions. First of all, how does a person find out, once they've been vaccinated, how do they find out where, if they have too many spike proteins and where those spike proteins might be located in their body?
I want to say that's the billion-dollar question or the multi-billion-dollar question. And I'm working on that with a couple of different laboratories. So there have been some scientific papers out of academic institutions that have done spike detection at academic levels of testing, and the equipment is very expensive, and the protocols are slightly involved in terms of showing presence of circulating spike protein. Harvard did a study about 2 months ago where they showed these young men that had myocarditis. They were the ones that still had spike circulating, whereas the young men in the study that didn't have myocarditis didn't have circulating spike protein. There are several studies. Dr. Fertig out of France showed not just spike circulating, but the mRNA persisting and circulating for several weeks and up to a month in certain patients. Dr. Bonsall, Journal of Immunology, showed spike circulating for about 4 months. The thing is, there isn't a commercial test available yet. There's a couple of technologies. We've tried one in the laboratory here, done some of the normal control assays. So far, there are 3 different techniques. And again, there are several of us collaborating. Unless you're at an academic institution that's actually looking at it, which there's very few because the funding didn't go where it needed to, and that this should be the question at every academic institution in the world right now. They should all be looking at this, but it's up to the smaller private entities that actually care about the patient and care about what's happening to the human body to pool our resources and try to do this. So we're working on it. There's no easy answer at the moment.
So it seems like if you suspect maybe that there's spike proteins, let's say in your ovaries or in your testicles or in your heart or something, you'd have to get maybe like a biopsy or something of those
Correct.
areas. Okay. And that
Correct.
wouldn't be
And
easy or cheap.
no, not without risk. No, certainly every medical procedure carries its risks. And there's only a handful of labs doing the staining. I do it, some colleagues in Germany, a couple other labs in. I met with some pathologists recently in the southeast of the U.S., and they're how do I say it? They're getting the technology on board to do
Okay.
the same test. So I'm trying to educate my colleagues. I encourage any and everybody who has a family member that's experienced sudden death, demand it of your coroner and your medical examiner. These are not esoteric tests. These are commercially available reagents now, and these are standard techniques we've used in the laboratory for decades. So it's something that any curious mind should do. I always say you can't find what you don't look for. So it's something we should absolutely be looking for, especially in this era of what we've experienced over the last several years.
What would a person say specifically to the coroner if they were looking for, if they wanted
Okay,
this?
my family member passed suddenly and they were healthy. This is unexpected. Um, I would like their tissues to be tested for the presence or absence of spike protein and or virus, because we use other stains to control. If it's only spike protein and that nucleocapsid in the membrane and other proteins aren't present, then we've excluded by deductive reasoning that it's not virus, it's spike protein from the injection itself. So we can tease out with a high degree of medical certainty that it's been vaccinally caused and not virally caused.
So we do know that the virus obviously causes spike proteins to swarm your body when you get infected. So what is the difference between getting infected with the virus and getting vaccinated? Have there been studies that show that there is a big difference? And then I'm curious about the more vaccines you've gotten, does it then go up correlating with the number that the number of jabs you've received? And then what happens to the people? Have they been studied compared to those who are not vaccinated, those who got vaccinated and then also ended up getting the virus?
Yeah, a great series of questions. So, yes, when you get a natural infection with the virus, you're going to replicate virus for a small window of time. In an immune competent, reasonably healthy individual, you may have virus replicating for 3, 4, 5, 7, 10 days, depending on your underlying health. But then your body starts to clear it. And again, it's a natural RNA, not a synthetic RNA. So your body is going to kill, like you get a common cold a week later. There's no virus. Your cold is actually the symptoms of your body clearing out all the debris. Now, in some immune suppressed individuals, we know that the virus can replicate for longer periods of time. Yes. However, because we're using this synthetic RNA, individuals that keep getting shot, stacked on shot, stacked on shot, are producing spike protein for longer and longer and longer periods of time. Now, in immunology, one does not vaccinate after one's recovered from an illness. And Fauci said in 2018, hey, the best vaccination of all is recovery from the disease. Of course it is. And so to get, to this whole construct, the CDC was saying, well, if you have the disease, go ahead and get a shot. You'll have super immunity, which is equivalent to Superman. It doesn't exist. So you actually cause a hyperimmune response by getting a shot on top of a COVID recovery. And so there are some studies that tease out that some of these adverse events are happening at higher rates in those who have gotten a shot on top of COVID recovery. And early on, there was a colleague in Pennsylvania who said, look, screen before vaccine. If you're recovered from the disease, don't put the immune system into overdrive. And this, again, goes back to basic science, basic immunology. And we collectively lost our medical mind as a nation and as a world. These are basic principles that you don't want to hyper-rev the immune response. And so we are seeing additional harms in a lot of these bad advisories that have been given to the population.
So you're seeing a definite difference between those who have not been vaccinated but ended up getting COVID and those who were vaccinated, whether they got COVID or not. There's a difference in the blood clotting, a difference in all of these, maybe the higher rates of cancer or higher rates of all these other things that we're now seeing, myocarditis, pericarditis. Are we seeing higher rates in the vaccinated versus those who just ended up getting COVID?
Yes. Plain and simple, yes.
How much higher?
I don't know if I could put an actual number on it. There's still some individuals that got severe COVID that, Dr. Bruce Patterson's work at InCell Diagnostics showed that some of them had persistent spike protein. But again, these were the more immune suppressed individuals. And so some of those long hauler patients do have spike protein circulating. Again, it's the inability of the body to clear normal pathogens. So there is a set percentage in the population that has pre-existing conditions that predisposes them to being sicker longer and having viral fragments longer. But overall, statistically, and this is where it's very frustrating, I'm feet on the ground. Any observation I make is criticized as anecdotal. You bet. Absolutely. But when you see 40,000 biopsies a year through the microscope and you see a 5x change in certain types of cancer after the rollouts of the shot, well, that's what we do in medicine. The primary observation is what matters. And then you collectively share that with colleagues and say, are you seeing something different? Are you seeing something different? And we as pathologists, we're the quality control of medicine. I like to joke that the pathologist is the most important doctor that you never meet, that you always hope is right. And, life and death is in our eyeballs every day. That's what we do. So that's what happened early on in the AIDS epidemic is pathologists started seeing unusual infections. They're like, what's going on with this population? Well, same thing in COVID. When I started seeing, again, with COVID, I saw clots, but when I saw an increase of clots and then I saw an increase of other viral outbreaks, like, why are all these patients getting shingles or molluscum that, again, we have a steady state of disease that we see in the laboratory, and all of a sudden you see an uptick and you're like, oh, something's different. Yeah, this shot is different. And so making those observations across the board and then compiling those with others, this is where the government has all the data. We code for everything in medicine. There's a code for every diagnosis. And those databases are hidden. And those databases are being controlled by agencies around the world. It would be very simple for me to take the top 20 most common cancer codes and say, let's look at the rates of these in 2017, 18, 19. Let's look at them in 2020. Now let's look at them in 21, 22, and 23. And there are statistical trends where we already see it happening. There's a CDC trend data subset where cancer rate is at what we call a 12 sigma right now, which is astounding. But you can go in because they have the matching data for who's vaccinated and who's not. So it's there. It is being obscured and it is being withheld. And I think it's for nobody wants to admit they did something wrong. Everybody wants to think we tried to do something helpful, which hooray. But at the same time, in science, science should be objective, not subjective. And and we need to tell the truth at all costs. And that's where I get very frustrated. That's a project that I'm working on with Ed. I think we have a way to get into those data sets, and we'll be able to show that uptick. And around the world, wherever I go, I have oncologists and radiologists and family docs come up to me. I was on a call last night with several colleagues around the country, many of whom you know, and one of the oncologists was talking about the leukemias and lymphomas and prostate cancers that he's seeing that normally he treats. He's been doing this for 3 decades. He knows how these cancers behave. And all of a sudden, the patient goes and gets a booster and their cancer is stage 4 instead of keeping it in check. And, there's complex mechanisms. There's genes that the spike protein binds to, P53, tumor suppressor family of genes, the BRCA gene. There's all sorts of cell cycle pathways. There's what we call immune tolerance, this getting 2 or 3 shots instead of your body recognizing this as a pathogen. It starts to treat it as an allergen and eventually says, I'm just going to tolerate this protein. Now that protein can run amok and do all sorts of other things. And this is a subcategory of antibodies called IgG4. If I had a peanut allergy or a kid had a peanut allergy, you'd give them a whiff of protein constantly over time, and eventually their body says, I'm going to stop hyperreacting. Well, that's what's happening with exposing people over and over and over and over again to spike protein is, hey, you want tolerance to allergens, that bee sting, that peanut, that dander, whatever, but you don't want tolerance to pathogens. And we've created a big immune tolerance problem in the population, and that can lead to problems. And also, this spike protein is destroying certain cells that are responsible for killing cancer, certain types, we call them natural killer cells, counts of natural killer cells in these cancer patients that have received 3, 4, 5 jabs, tanking. Just, there are just so many things. Before one uses a new technology and uses a new drug, a new modality, these are things one studies in a laboratory setting for years. This is why it takes years to bring a drug to market, because you have to know all these things beforehand. And in retrospect, too, and Dr. Ioannidis at Stanford knew this early on, this wasn't as deadly as everybody predicted. It was affecting elderly, comorbid, and people with underlying conditions. But, it ended up being a bad flu season overall. And then people are still treating Omicron, which I jokingly call coldvid, not COVID, because it's mutated enough to be a common cold for most, except for in those who are immune suppressed because they got too many shots. So we're still treating it, and we still see people masking alone in cars and whatnot because they're worried about dying from that Wuhan variant, which is extinct. So again, this mass hypnosis of thought has really led to aberrations in how we think scientifically, which is unfortunate.
Is the spike protein, when it's getting into these bodies and causing these cancers, causing the myocarditis and the pericarditis, all of these different, are these people who, is it I guess I should ask, is it causing these ailments, or is it just, or is it taking people who are predisposed? So if you were already highly predisposed to getting cancer, and then you end up getting these jabs, it kind of brings that forward, rather than maybe somebody who's not at all prone, and then they get these jabs. Do they suddenly end up with cancer and myocarditis? Am I making sense in that question?
Yeah, and it's a great question because all of us have atypical cells all day long, and we have mechanisms that say, hey, this cell has a mutation, and these natural killer cells, they shake hands. Right now, you and I are sitting here with about 30 billion T cells circulating in our body right now. And a subset of those, they shake hands with every cell in your body about every 30 to 45 minutes. They're like, hey, friend or foe, friend or foe. Oh, wait a minute, that one looks different. Let's take that cell out. And so that's a constant immune surveillance that we have. So when we suppress that surveillance system, say I go out in the sunshine and get sunburned, and now I've got some atypical cells that want to become a skin cancer. Normally, we've got little repair mechanisms that would come along and say, okay, let's either repair the DNA in that broken cell or let's get rid of that cell. And hence you get the blister and slough off and whatnot. But if someone is predisposed, like you mentioned, or even is normally just having a handful of atypical cells, these surveillance mechanisms, because of the nature of these shots, the suppression of these basic mechanisms, then the body allows these cancers to take off. And this is one thing the doc mentioned last night. He has cancer patients who have been cancer free for 3, 4, 5, 10 years. They get these shots and their cancer is back, stage 3, 4, gone quickly. And that's what I'm hearing a lot of from my clinical colleagues, is these normally manageable cancers all of a sudden act like hydras. And that's the tragic aspect of this, is to continue to insist that people get what we know to be a toxigenic protein that doesn't just cause clotting, doesn't just cause cancer, but causes autoimmune diseases and causes so many other harms in the human body, to say, hey, keep getting a spike protein. Gosh, no, horrible idea.
Are we all vaccinated by proxy? When you mentioned previously that that they were finding spike proteins in testicles, it just seems like any partner to that man would be injected with spike protein.
Yeah, the spike
Maybe
protein itself. And the question becomes, what about the mRNA? Well, there was a study in JAMA that showed spike protein being excreted in breast milk 48 hours after an injection. So shedding of the mRNA, yes, it happens. Shedding of the spike protein, yes, it happens. By proxy, most of us have had COVID. 90+% of individuals in most nations have had COVID. So we have a certain degree of population immunity against multiple variants at this point. So a lot of people do worry about, the shedding question. And one of my arguments is, when you get a natural infection, here's where you're immune: in your nose, in your eyes, in your throat. You form a special kind of antibody. It's like little brooms or mops that mop up any time that antigen pathogen comes forward. Injecting in the arm, you form an IgG response, but you don't form the mucosal response. So to again, going back to bad ideas compounded on bad ideas, to try to inject here for a respiratory pathogen was a horrible idea, because you're not going to form the type of immunity one normally wants to form against a respiratory pathogen and the door where that pathogen enters. Going back to the question, is spike being shed in sperm? We don't have the studies yet. Is spike being shed in breast milk? Yeah, we do have the studies. Is mRNA being secreted in breast milk? Yeah, we do have the studies. In everybody is it happening? No, that's the good news. In a set percentage of individuals? Yeah, we're all biologically different. And here's another just little tidbit. Nobody got the same vaccine. How can I say that? Well, if you look at the data out of the European Medicine Agency, leaked data showed that the vials were only 50% pure mRNA. What does that mean? It means 50% was fragmented, coding for other proteins potentially, not spike protein. So other misfolded proteins, and some of it, just junk mRNA. We know in pathology that microRNAs are a known carcinogen. So depending on whether that vial was kept at temperature, whether it sat out in the sunshine and sludged, some people may have just gotten a bolus of sludge and nothing more. But other people got different lengths of mRNA that didn't code for proteins. There are data sets so the spike protein, if you weigh it, should weigh about 141 kilodaltons. We have Comirnaty data that shows proteins that weigh 100 and 190 on these gels that we do in the lab, but there's nothing that weighs 141. So it's like, what's this protein and what's this protein? It's certainly not spike protein that the body's making or these cell cultures are making. So that's the other just confounding variable, is the claims that this is going to make a spike protein, you're going to have immunity, et cetera, et cetera. The other thing is, we don't know whose body is going to make a ton of spike protein and whose body is not going to make any at all. And as a gene-based product. They bypassed all regulatory pathways. A traditional vaccine goes through certain testing, traditional drugs go through certain testing, but gene-based testing, you look for reproductive toxicity. You don't test gene therapy on pregnant women and insist women and children get it. We never do that in medicine. You look at dose-dependent toxicity. We didn't do that. And then to understand who's making what amounts of this protein in the body, that goes back to the question, where are the good assays to look at it? We don't know. These are all things that should have been known before it went into any single human arm.
Yeah, do we know why some people get really bad COVID and others don't? Or, just you take two people of the same age, they seem to be the same health, they have the same stats, and one of them ends up hospitalized, and the other one says, "Oh, I was totally asymptomatic. I didn't even know I had COVID."
Yeah, so three basic things that every hospital should have tested for in every single patient. Number one, what's the vitamin D level? Plain and simple. People have heard me joke, look, there's no such thing as flu and cold season, only low vitamin D season. If you had low vitamin D, I mean, even if your level was 30, you didn't end up in the ICU. So it's not like you had to have, superhuman levels of vitamin D. That one basic one, vitamin D levels across the population. The more obese the population, the more your vitamin D gets trapped in your fat, the less that you can get it into circulation to be the conductor of your immune system. Very basic. Number two, interferon. Type 1 interferons are antiviral and anti-cancer. This is one of the other cancer mechanisms. Spike protein drops your interferon amounts. Interferon, when it goes up, fights cancer, and it also fights viral infections. About anywhere from 10 to 20% of the population has an autoantibody against their own interferon. If we had tested individuals, hey, is this individual making appropriate amounts of interferon in responding to an infection, then we could have given them IV interferon to help fight. So those are two basic things. Then there's, those special brooms and mops, the IgA. Some people have what we call a secretory IgA deficiency. They don't make enough of it naturally. Had we tested those three things, we would have been able to stratify very quickly and very, very early who were the highest risk individuals. And then there was a great AI algorithm that looked at all the papers written on COVID, and the number one factor that showed bad outcomes was the word glucose or sugar. And we have a very obesogenic diet, too many carbs, too much high fructose corn syrup, too much sugar in the American diet. I call it the SAD, the standard American diet. But if your sugars ran slightly on the high side, that portended a poorer outcome. Just basic science principles.
Was the vaccine good for anyone? There is the data is out there that it did save lives. When I looked at the rates of death for elderly people, over the age of 65, if they got vaccinated, they did have better outcomes, surviving COVID, better outcomes of not ending up hospitalized. Of course, and my own dad asked me, should I get the vaccine? He's in his 70s and has like anybody in their 70s, has health issues. And of course, I'm not a doctor or a medical person, but I did a lot of research during the pandemic, and I said to him, look, the data's there that people who get vaccinated at your age group do seem to survive COVID better, do seem to not end up in the hospital as much. But that's the end of what we know. We don't know what it does to you after that. We don't know what the side effects, what the long-term anything of what that is. It seems, of course, there is an age where it seemed to do nothing for, didn't raise the rates of or lower your rates of hospitalization, or, there's certain age groups where it was pointless to even give it to them. But then there was that age group, an older age group, 65 and above, where it does seem to help them survive COVID better. Is it at least good for that old group?
Maybe early on, statistically, there was a subset where that had a window of protection. And I like to quote Mark Twain quite often. There are lies, there are damn lies, and then there are statistics. And so some of these models claim, X number saved, but some of these are models based on models. So when you hear the claim of, tens of millions of lives saved around the world, well, that paper was a model based on the original projected model that COVID was going to be worse than it was. I think in retrospect, years later, we're going to be able to tease it out, because the question also becomes, are they are they doing true comparators? So when you get into the medical literature, you have to see the confirmation biases going into the author, the paper, the funding, et cetera. For in some of the early statistics, it appeared to be maybe protective for a 2 to 3 week window. But then you bring up the salient point that what are the long-term harms? And that's what the excess death data is starting to show across the world, unfortunately, that the long-term harms may be worse than the short-term benefits.
Right.
And so at this point, I mean, in my medical opinion, based on the fact that these are expired shots for extinct variants, then it's not going to benefit anybody at this point. And then if they formulate a new one for the fall, the virus will be 3 steps or 10 steps ahead of us already. So again, it goes back to basic science. And I know, no, and here's the hard part. I mean, from a philosophical point of view, nobody wants to think that we made a recommendation. Excuse me, I'm so sorry. Nobody wants to make a recommendation that we did something bad or we did something that was potentially harmful. And so everybody wants to think, okay, I did something right. But at the same time, I don't want to sound cold, but as a scientist, you have to be strictly observational and say, okay, we did this, this happened, or we did this, this didn't happen. So you have to weigh that risk benefit. And I can say with certainty at this point, it's all risk, zero benefit. And that's just from the shape of the spike protein now. It's different enough that what we're doing isn't going to benefit. And so at this point, it's all risk, no benefit. Early on with those more aggressive variants, Wuhan Alpha, maybe a degree of benefit for a couple of months. I'm going to go back to my earlier commentary, however. Now we've formed an antibody. I think those that got 1 or 2 shots don't have that tolerance to the antigen like an allergen. But those who kept getting it, we may have a subset of the population that is now immune primed going forward for more adverse outcomes if along comes SARS-27 or SARS-29 or SARS-31. That's my bigger concern, is we will see more severe disease in those that ended up immune imprinting to those original patterns, unfortunately.
I do have one last really important question for you before we go is a lot of people ended up getting the vaccines. They didn't want to. They were mandated to get them, and now they're stuck with these spike proteins. Now they're stuck with the damage. What can be done, if anything, to undo the damage, to get rid of the spike proteins that are circulating through their bodies? I know you've mentioned remedies for blood clotting, such as nattokinase. My husband loves to eat natto. It's like the most disgusting looking thing on the planet. It's the fermented soybeans. He would eat them every day. I mean, he really eats them all the time. They're in our fridge. And after I heard you talking about nattokinase, I'm thinking, well, I guess maybe I need to start choking it down
No,
every
I take
day.
a tablet. It's much more tolerable.
Okay.
I've had natto before too. I had my daughter's boyfriend was Japanese, and so we tried it. I'm like, that's kind of funky tasting. I'll
It's
just take my
different.
natto. Yeah, it is
Yeah,
for sure.
it tastes like beer. You're eating these like beer beans kind of a thing. But when it's hilarious. My husband is a Caucasian and loves that, and I'm the Asian one, and I'm like, I don't know if I'm going to eat that. But what are some of these? What are some of the remedies? What can people do now? So a lot of people, it's too late. They're sick. They're suffering with side effects.
Mhm.
What can we do?
So the number one thing is we as a nation are metabolically unwell, plain and simple. I like to say the best doctor you'll ever meet is here right now, and it's not me, it's you, the patient. And so look in the mirror, you know what your health status is and things that need to change. Now, does it take discipline? May you need a doctor or a health coach? You bet. But cutting the sugars out of the diet, cutting the inflammatory foods out of the diet, you can take all the pills in the world, but if you don't take care of just the basic underlying health, then all the pills in the world may work to a small degree, but getting the body back into homeostasis. We as a nation are obese, let's be honest. We are insulin resistant, and that's a long medical lecture, but getting the body healthy, number one, making sure your vitamin D level is normal. Then, of course, there are a lot of different protocols out there. the claim of detoxifying or getting rid of the spike protein, those aren't scientifically proven. There are a lot of patients who've improved with a lot of empirical treatments. I love my colleagues over at the Frontline COVID Critical Care Alliance, flccc.net. I'll be lecturing with Dr. Merrick and Dr. Corey this weekend up in Wisconsin. Wonderful doctors. I work with them, always trying to figure out what are the things that help the patient recover best. It depends. There's not any one way of harm. It's not like the spike only does this, because some people have clotting problems. Some people have autoimmune problems. Some people have mast cell problems, which is an itchy inflammatory cell.
Yeah.
Other people have microbiome problems. There's so many pathways of injury that can be caused. It's not any one given thing. The protocols on their website are excellent. And again, I'm not preaching anything I haven't personally done. I lost 46 pounds about, 12, 13 years ago. And so skinny, healthy me that you see now was, dad bod, a dozen years ago. My sympathy pregnancy pounds for each, I have 6 daughters, and each daughter I gained my extra couple pounds. So optimizing your health is the best thing you can do. Now, fasting is a wonderful way of getting the immune system to turn over. Intermittent fasting, that's 16 hours. You can have water, you can have your coffee, tea. But I 4 or 5 days a week, personally, I will not eat from about 8 p.m. until noon the next day. And then I'm a big fan of getting out in the sunshine, not just for your vitamin D, now that we're getting into vitamin D season, but also for the near infrared light. If you can get near infrared light therapy, that helps reset a lot of immune system functions. There are many medications, many supplements one can do. Move your body. I mean, fantastic studies out of the UK showed, it was almost a 400,000 patient study that showed those who moved their body, just a modicum of exercise. Of course, the things that they stopped us from trying to do, during the pandemic, but
Yeah.
just, you don't have to go to the gym and get a 6-pack of abs. You just move your body, just basic things. And then do look into some of the protocols, but be wary of the excessive claims. And then there are a lot of good doctors still out there. I'm not saying every doctor blew it during the pandemic. There are still wonderful healthcare providers who are trying to, solve problems. And there are some long COVID clinics forming now. So, find who you trust and be your own best doctor.
And what is the stinky soybean? What does that do for people, just so that they can understand?
Oh,
So if you
yeah, the
eat them
stinky
or if you take the pill.
Yeah, so I take 100 milligrams a day. It breaks down fibrin clots. So Goldilocks effect in life, just because a little bit may be good doesn't mean a lot is better. So fibrin is part of clots, and it's called a fibrinolytic. It breaks down fibrin in clots. So that's the benefit of the stinky soybean stuff.
And how was this discovered? People in Japan eat this,
They
the
do.
fermented soybeans.
They do. And it's an interesting history. Traditionally in northern Japan, it's eaten quite a lot. And one sees very low rates of death from strokes and heart disease in those regions of Japan. And so they did some retrogression analyses and tried to figure out what's different dietarily in this region than other regions. And nutritional studies are challenging to do. But then laboratory studies were done showing, well, what is the benefit of this molecule, this little enzyme? And that's the benefit. It breaks down clots.
Huh. So eat your stinky soybeans or take the pill. Sounds like do that. That could help with blood clotting, anti-inflammation diet. It sounds like intermittent fasting and get your sunshine, get your vitamin D. Those are the things that
And
maybe
move your
people can
body.
do.
Yeah.
And move
Move
and
your body.
exercise. Go on walks every night or something like that. Just get out there
And
and
you know what else? Well, 2 other things, if you don't mind me throwing them on real
sure.
quick. Don't forget to sleep. If you
Yeah.
if you get insufficient sleep, your immune cells become, I say, less sticky. They talk to each other less well, and that has to do with immune stress. And the other thing that's really important is a meditative practice, a prayer practice, or whatever you may practice. Do it, because that calms the immune system to where it functions normally and not excessively. And then being in community, having a tight-knit group of friends. Those who have 5 close friends live longer. And just having a community to which you can connect and relate decreases depression rates, it decreases all-cause mortality. There's so many basic, simple things that Life can be more simple than I like to joke. Health doesn't come from a pill, a bottle, or a needle. Most health comes from the lifestyle choices we make, and then there are good medicines we need, and when we need those, we can use them.
Yeah, absolutely. Dr. Ryan Cole, thank you for this conversation. I wish we could go longer because I know you have so much information and so much knowledge to share with people. And it's a shame that this type of conversation is censored on platforms like YouTube. It's a shame that you've been censored and heavily demonized, and that I know that you've suffered a lot just by telling the truth, just by being out there, and very brave to put yourself out there in this way. And I know you do have a big family. You have mouths to consider feeding, and so it's very risky to go out there and just share science. I don't know why that's risky, but I guess it was for guys like Galileo, so I guess it would be for you too, which makes no sense. You think that we would have progressed as a society beyond that, to where science, we want to hear all the science, we want to see different perspectives on things, and I do hope people are waking up more. I hope that more of your colleagues, maybe the ones that maybe you had experiences where there were some who in the beginning were like, no, you're wrong, but now they're like, well, okay, actually, you're right. I hope we're seeing more of that. Are you experiencing that?
We're getting there. People are still afraid to speak out because they've seen what has happened to those like me and my other colleagues. But at the end of the day, would I do it all over again? You bet. Science is science, truth is truth. What I do is objective, and it's about an oath I took to the patient. I didn't take an oath to a three-letter agency or a hospital or an administrator. I took an oath to the patient. That's what matters. I do it all over again because saving lives is that oath that we took. So it's an honor, Kim. I'm grateful to be able to have had a voice to share what I know, and will continue being a truth teller like you are. And I'm always open to being wrong. I think that's the key to good science, is dialogue and saying, I could be wrong. And if I am, please teach me so that I may do better on behalf of my patient.
Thank you so much, Dr. Ryan Cole.
Thank you.
Well, I hope you guys enjoyed that conversation. Dr. Ryan Cole is just a fantastic human, very nice person, and also very science-based. As you could hear from that conversation, he knows his stuff. So really grateful for that conversation. Thank you guys so much for watching. Thank you for being here. I hope you have a great weekend. We will be back Monday with another great show for you. Same time, same place. Until then, have a great weekend. Good night.